Hey, morning, Dr. Neal.
Good morning. We saw that empty chair there. Didn't know if we were going to virtually or not.
Georgine got me all lined out. I was all good. I came in early.
Wonderful.
He did, but I thought he was trying to escape. That's what it was.
It won't work.
No, it
Not a
won't.
couple of years ago. I'm resolved to I know what my station in life is.
I told him it's raining in Owensboro. We're sending it your way. You may already have it in Glasgow. I don't know.
It sprinkled on me a little bit this morning when I was out walking, but I think it's coming. It's not quite here yet.
Yeah. Well, we've needed it. We've had a beautiful fall with very little rain. We've still been watering the yard.
Let's see here. Where am I at? Here.
Dr. Thornberry, it looks like we have just a few more people trickling in. A couple more TAC members are trickling in from the waiting room. So if you want to give it just a few more seconds, they should be joining.
No worries. We have Dr. Gupta. Good morning, Dr. Gupta.
Good morning.
It looks like all TAC members are logged in.
So we have, do we have Dr. Tran here too?
Yes,
Hey, how you doing, buddy? I see it. I see you now.
thank you.
Dr. Thornberry, your
Yep.
waiting room is cleared. You can start whenever you'd like.
Good morning, everyone. This is Dr. Thornberry. This is the Kentucky PTAC meeting. We meet under the auspices of Title 19. Today is, let's see, November 17th. It's 10 Eastern, 9 Central Time. We have, let the record show that we have quorum. We have Dr. Linden here. We have Dr. Tran, Dr. Gupta, Dr. Neal, and myself. That should establish our quorum. I'd like to call for any adjustments, addendums, or additions to the prior meeting's minutes. And if there aren't any, I'd accept the motion to accept those.
I motion to accept the meeting.
Dr. Tran, is there a second?
Second, if you need it, Dr. Neal.
Very good, Dr. Neal. All in favor?
Aye.
And without any dissent, we'll accept those. We have no old business on my agenda. Does anybody have any that I don't have marked? If we don't have any old business, I would like to just jump into item 5, which is our new business. This is the therapy. Our colleagues from Rehabilitative Medicine and Physical Therapy, I believe, are here. Do we have a guest? Cody, are you here with us today, Cody?
Yeah, Dr. Thornberry, is someone from the, did you want to talk about the therapy TAC?
Yeah, I was going to. I think we have an invited guest here.
I am scrolling, Dr. Thornberry, and I don't see that he's logged in yet. So I asked Kelly to resend him the invite just since this is not his typical TAC day, just as a friendly reminder. So as soon as he logs in, I will let you know.
Well, let's just nudge, if it's okay, let's just take the second item then. That's Senate Joint 54 of 2003 update. Cody, I have some notes on it here, but I'd welcome if you'd walk us into this, please.
Sure. So Senate Joint Resolution 54 was a resolution that passed this legislative session, and it directed the Department of Medicaid Services to look into a reimbursement model that would take into account area deprivation index scores. I believe the report from the department was set to be for this month. And so this is something that the TAC had talked about previously. So I just wanted to, I think you all were curious if there was any update from DMS on this.
Well, do we have anybody from DMS that would like to join us or can offer some insight where we are?
Hi, this is Justin Derringer, Acting Director for the Division of Healthcare Policy. So that's,
Hey, Justin.
how are you all today?
Good. Thanks for joining us. I didn't see you come in. Thank you.
Absolutely. So yes, that report is complete and we can send that out to the TAC for you all to look at and digest. It's in depth and there's a lot to it. So it'll be some good reading for but it's a lot to kind of go over on here, but I'll make sure to get that sent out so that you all can have a copy of that. I think that was completed and sent in November the 1st.
November 1. Do you have 2 or 3 highlights that just stick in your mind? We don't really have to discuss it. We just kind of want to know what was impressive to you.
Yeah, it's it's for me, I think it's an interesting model to look at and to consider. I think that's my takeaway. We're always looking for something new and interesting to think about, to consider. I think it's something definitely in that area. That's something that we should continue to talk about, think about. There are a lot of complexities to it. It would be, as with anything, there are pluses and minuses. I think it could assist in some areas where we see pricing that maybe not fits the area that where the services are being conducted. But on the other hand, it could cause potential of provider shortage if we had 20 miles difference separating areas, and we had providers in one area receiving one way rate, providers in another area receiving another rate. It'd be real easy for providers to move from one area to the other, just kind of move an office. So there are a lot of a lot of thoughts and considerations to go into it. We're looking at some other states that are we don't really have a lot of examples of other states that are fully doing that model, but we have a few states that are kind of looking into it and some systems and that they've looked at to possibly use. So we're kind of looking into that too. Just a lot of things to think about, a lot of questions and thoughts it brings up. So I think if nothing else, it's a great thought-provoking study that really looks at some of the things that we could be doing and thinking about moving forward.
Justin, if I may, this is Twin Tran. Just dumbed down version. This is again an attempt to enhance and improve access to patients in underserved areas. Is that accurate or?
Not necessarily. It's I think maybe that was the thought, but I'm not sure if it. When you look at the study, you'll be able to see it. It's more of a look into different pricing methodology for different areas and how to calculate that. And so I think that's kind of the idea, but then you get into pricing rates on increased access, meaning areas where there's a lack of access or a lack of care, increasing prices in those areas. But then you also have areas where the cost of providing care is higher via workforce employment. But then you have areas of where care is higher due to access issues. For instance, a lot easier to get around in Louisville than it is to get around in Pikeville. But at the same time, clinicians and other staff are more expensive in Louisville than they are in Pikeville. So there's a lot of different kind of floating, moving parts involved, and you kind of see that more in the study.
And of course, the incorporation of telehealth technologies and processes certainly will throw a wrench into a lot of those modules.
Yep, that's a whole nother aspect of it. We've tried to open up as much as we can. As a matter of fact, any area where we're not limited by CMS guidance or regulation, we've tried to open up telehealth as a use to be able to use for physicians at their discretion and all clinicians at their discretion. So yeah, that complicates things dramatically with this type of model. And we've seen that access to care be extremely beneficial in multiple areas, specifically right now in our school-based services area and in the areas of where we have provider shortages or we don't have enough access to care, like certain areas in eastern and southern Kentucky.
Dr. Neal, do you have a thought on this, sir?
Well, actually, about 30 years ago, we floated an idea like this. And as much as we looked into it, the further we got into it, it looked like it was going to create more problems and more ill will than it was going to be positive. And I think there may be some positives about it, but I really don't think that's the way we want to go. That's my opinion.
I guess that my kind of thought on it is this is something for the legislature to, in their wisdom, decide how they're going to handle this. I think the reason that it comes up before us is it looks to me like the last few years we've been kind of charged with almost a different problem. Generally, we would probably be the sounding board to make the case for some type of physician issue. And I think that's what was intended. What we've ended up carrying is the mantle of this. I'm seeing it as kind of a failed system where our primary care is just imploding on us, and we're trying to figure out. We've really championed. I think it's fair-minded to say that we've championed that effort to say, well, we think the solution to our problem as best we can. The most affordable way to address this is Starfield's method. Since that, I don't think that, again, that's, I would make the case is not really, that law has not been disproven in 40-45 years. And if we're going to try to work through that lens, how is it that we're going to, how can we propagate this to provide the services for basically 1 in 4 Kentuckians that are on some type of assistance program? And I think Justin gave a fair-minded, again, I would say he gave a fair-minded presentation of there are pluses and minuses, and sometimes we have unintended consequences when we look at these different models, and maybe there isn't just one model, maybe it's a cohort of all of them. Does anybody else on any side or any of our MCO colleagues have any thought? We've not really don't have the report, but I don't want to go by getting their insight or their wisdom on this.
Good morning. This is Dr. Thornberry. This is Stuart on with WellCare. I don't know about
Stuart?
any wisdom that I have, but just as background, the senator that sponsored this has pushed for years about increasing rural reimbursement rates, and I think that's what's driving a lot of this is basically trying to shift it to something where we pay rural providers at a higher rate. And I think he's been pushing this for years. So I think that's kind of the driving force behind it. But, I mean, ultimately, we all want to see outcomes and quality, more than anything. But just give a little, I guess, background.
Yeah, I think that the mechanism that we have in our country to solve these problems is politics, and politics is about power, and power is about priorities. And everybody has their own priorities because everybody has, again, a different lens, I think, to look through it. I think that what we're doing needs to be improved because what we're doing is, I don't think we're receiving the benefit of what we'd like to receive in it. Well, without the report, and again, we are moving into a legislative session, it'll take on a life of its own. Any final thoughts on this before we kind of nudge the agenda forward a little bit?
I think we'll talk more about it when we get into the last part of new business, talking about the North Carolina and other models. And
Yes,
also
sir.
Academy of Pediatrics is doing and some other things that are.
Yes, sir. Do we have our guest in from the therapy TAC chance? Well, if we don't, let's go ahead and move forward just a little bit to the workforce issue. We now have this back. Cody, can you set this up for me, please?
Yes, sir. Sure. So, by way of request of the MAC and their work with DMS, the cabinet and DMS reinitiated their workforce report, which was essentially a kind of a follow-up report to the study that was done by Deloitte several years ago, and just thought it would be beneficial to hear kind of the physician workforce data and the perspective from the cabinet on that data. If there's someone here that would want to discuss that.
Did anybody, Justin, you want to take a swing at this pitch, or do you have a colleague that wants to bat next?
Well, I'm hoping that maybe somebody else is on here that has a little more. I haven't really had time to study too deep into it myself, but I will make sure to get with the appropriate personnel and get back with you all on their thoughts on the report.
Well, I certainly remember when we had when Deloitte was in here. I guess it must have been a decade ago, but I remember when that first started. Can you shine some light on that, Dr. Neal?
No, not at this point any more than what we've talked about before. Are you talking about the full report that we had on the workforce?
Yeah, I got a snippet on it. Cody, I bet you know more about this than anybody. Can you? What are your thoughts on it? I very much value your opinion.
Yeah, it's generally I haven't. I went through and looked at it. I haven't took any detailed notes on it that I have here in front of me. But just off memory, I think it affirms a lot of what you all have been saying for the last number of years, that we have a significant physician shortage. We have a significant shortage of primary care physicians all across the state. It's in every region. It's not really specific to any area. It's everywhere. And we have a number of counties that don't have a primary care physician, which is alarming. And so I think it just affirmed a lot of what we knew, and shows that we have a lot of work to do in growing our physician workforce and improving our numbers.
Dr. Thornberry, if I may comment.
Please, Dr. Trim.
This is a topic that's been discussed intermittently, even at the KMA board and other societies. And I just attended a national meeting, and this topic was discussed. And I believe Kentucky is one of the states that will face a pretty significant physician workforce shortage in the next coming years. And many societies, to include KMA, have recognized this. And I believe several years ago, we attempted a campaign to figure out how do we recruit young physicians to come, and then how do we retain them? How do we keep them here? And I believe there was an AMA report years ago that talked about, if you're able to bring a clinician into your community, not only will you bring the healthcare associated with that, but you will bring businesses and whatnot to the area. And I don't think you have to be very smart or do a thorough analysis to look at Eastern Kentucky and realize it's becoming a ghost town. There, our population seems to all be deserting the state. And so I think, I don't know how to proceed, but I think someone needs to start helping us look at how do we recruit, how do we retain, and how do we bring physicians? Because I think physicians are going to be one member of the population that can help contribute to attracting others to stay or to come to Kentucky. So I think we may have to seriously look at retaining our physicians and then recruiting young ones.
Thank you, Dr. Tran. Dr. Gupta?
Good morning, everybody. So actually, Cody, I remember you sent me a pretty nice summary of that report. And just from the top of my head, they did make some suggestions of how to recruit and retain physicians at the end of that report. And some ideas that I can remember were, you know, making it easier for international doctors to practice in the US and practice in Kentucky. And also another thing that I remember was, you know, loan forgiveness to new doctors. So there were some ideas in there, and hopefully, you know, the legislators will really look at that report and implement some things.
Dr. Thornberry, I can give you a few numbers out of that I've got off the top of my head, if you'd like.
Yes, sir.
Basically, we have, of course, part of the problem has been looking at the licensing information, which you know a lot more about than I do, was the question of where are these people actually? So what we're seeing is there are about, and this was reported at the BOAST forum several weeks ago that I spoke at, we've got about 5,000 nurse practitioners in Kentucky, and that has been going up pretty rapidly. We have, as I recall, about 2,700 primary care physicians outside of pediatrics, and we have about 600 pediatricians. Part of the problem with that is that half of both the nurse practitioners and the physicians, primary care physicians, are in Louisville and Lexington. And so that decreases those numbers very rapidly. And as you stated earlier, we've got some counties that have little or no physicians. So I think, and the other thing that's happened is that the pay scale for primary care physicians has stayed pretty flat at a rate that will not entice them to become primary care physicians, whereas the salaries of nurse practitioners has gone up in double digits during this period of time. And I'm not saying that's necessarily a good or a bad thing, but those are some of the numbers we're doing with. And Asherman is correct about some of those things at the end, but we're not seeing, for example, we started a family practice residency 2 years ago in Owensboro, and we graduated 6 this past year. 4 left the state, and the other 2 have joined the program as instructors. So we actually netted 0 out of that 2-year program. I don't know about the Glasgow program, the Bowling Green, or if there's one there, and what is it, Madisonville and Pikeville, and one in Northern Kentucky. Somebody else may have some, but it looks like that just increasing the number of residencies is not necessarily going to get us more primary care physicians, but we can talk about that forever. So that's what information.
I think you make a couple. I think everyone here's made some very good. There's a lot of water here. You're correct that I would tell you I've been on workforce committees for probably 20 years in one form or another, or in one group or another. And my take on it is kind of like this, just my observant take on it. It reminds me of a family that has, say, the children are loved, they're taken care of, and you know they enjoy being around their parents. They go off to college, they come back home when they get at Thanksgiving and Christmas, and even after they marry and have children, back in those holidays. And when you have a good place that you feel like is your home, it becomes your home, and you have a relationship to it. When you have a place that's not your home, the children sometimes are trying to get out at 12, 13, 14, 15. Sometimes their lives are not that great, but I think that there's no secret in Kentucky that we train doctors for a lot of other states, and the great majority of them aren't Kentucky. And I don't know how long that's going to last. I mean, at some point, somebody's going to pick that up. Some article is going to be written about it. Somebody's going to get this epiphany, and at some point, that's likely somebody's going to say, well, why are we funding all this? Why are we training all these physicians? Why do we have 3 medical schools if they're not staying here? Because again, we're spending a lot of the Commonwealth's money and a lot of our Commonwealth resources. The intention was to build these facilities so that we would train our own doctors. But the doctors, I can tell you again, I have some pretty firsthand information on this, that they're leaving the Commonwealth in droves. And so I think, moving that ball on a little bit more, why is the environment not that great? Well, in all fairness, when you're paying your primary care doctors half of Medicare, Well, what does that mean? That means that every case that you see with Medicaid, every single case is a money loser. It is impossible to make money on that. Now, not that people go in to do it, but you can't force them to go out of business. I'm talking about independent prices. If you're, say, health system, you're going to be paid Medicare rates. But that was negotiated, I believe, last year. But if you're an independent primary care physician like myself, every case you go in there, you're trying to do the good work of the Commonwealth, or maybe you're a faith-driven person like I am. But it gets very, very hard when you know that every case you go in, you're going to lose money on. And I just have to admit that I was in a meeting recently with a very senior person, and it just seems like they didn't understand that. I just don't, I was really left aghast that, you know, I was under the impression you guys make plenty of money and you can promulgate these services. I'm like, no, wait just a darn minute here. Even 3 or 4 years ago, the government and the federal government is not the swiftest thing in the world. They passed G2211, which I guess they decide to go again. That comes at 2021, January 2024. It'll go into effect 2024. Is that correct?
Yeah, that's correct. Assuming it's included in the final bill that Congress passes.
And I think that's some way to try to adjudicate what you're asking these people to do. It's not like you're asking them to come in and solve one issue of chronic kidney disease or one aspect of cardiology. It's like you're asking them to solve 3 and 4 and 5 problems at a time. You're asking them to do their preventive medicine. You're asking them to produce their cancer screen. You're asking them to do all this. And then again, I was given a sheet of paper not long ago. By the way, we want you to fill this out too. I'm like, well, really? I mean, on top of all that. And I mean, it's very, very frustrating. It's almost like a mechanism to purposely put these people out of business. I just don't understand it. And I think, well, you know, maybe the philosophy of our MCO colleagues is, you know, maybe they feel like that physician assistants and the nurse practitioners are going to drive this primary care, that's just the model. And I guess that would be okay, but I just would like to know where in the heck it's worked. It didn't work at Hattiesburg. It certainly didn't work for Kaiser Permanente a decade ago. I mean, I have good buddies out there that told me they almost went out of business because of that. I'm just trying to figure out, well, what's the philosophy here? We know in medical schools, if you bring children in, I would call children at this stage of my life, young adults in, and you bring them from rural areas, and you bring them into medical school, you get them out there with AHEC, that they're more likely to stay. But if you can't actually afford it, well, then there's no way that they can stay, or they're not. And then it becomes a death spiral, because once you lose the primary care doctors out of an area, there's nowhere to go back and mentor. And we don't have a mentor. Like, well, why would I go back there? I mean, no one else has chosen to go and do that. It's very frustrating. I feel like we've had this same conversation really for about 5 years. Just, I mean, I don't believe in that. I don't believe in whining. I believe in letting myself whine myself. I think that these are just the realities. These are just the factual basis of what we have. And I think it all came to culmination last year. We had the lady here from the Commonwealth Fund, and she was like, we presented this to her. Well, what was your solution? She goes, I don't know. And I'm like, she's the national expert, and if she can't figure it out, well, I don't know what to tell you guys. But it's going to be a problem. And I think, again, my real concern is just watching it the last 2 or 3 years. I kind of wonder if we've gone past that event horizon already, where the system is so broken, you can't fix it. Like, you think you can fix it eventually, you think you can salvage it, but it's gone to a point where your senior physicians are so old that they're getting out quickly. The new physicians are in Glasgow. We kept no one. We haven't kept anyone for the last 3 years. They all leave. They all go somewhere else. And so I'm just trying to figure out where these people come from and why they stay. And you say, well, I guess the answer, the common say, well, this is not my problem. You could do that, but then again, if 1 in every 4 people have Medicaid, then you're affecting every physician in the Commonwealth. I mean, almost all of them. There's a few people probably doing cash and carry, but I mean, I guess it does become your problem somehow. And I guess we're trying to help you figure that out. Though I don't really. Maybe this is just a good place to walk into North Carolina. We've looked at this model. It's working. Cody, can you give us something about this? I think that is working in North Carolina. If I'm not mistaken, they've re-upped that. Is that not true?
Yeah, so North Carolina to go back a little bit with the rollout of the ACA, there was a mandate on states that they had to reimburse primary care providers at 100% of the Medicare rate for 2 years post ACA. So I believe it's from 2012 to 2014, states had to have that in place. I believe most states by now have gone away with that, but North Carolina has chose to retain it. And we were looking at their state plan amendment. This was a recommendation that came to us from the American Academy of Family Physicians. And we were looking through the North Carolina state plan amendment, and essentially it does what I just said, where they set there's a number of codes that are set out in the ACA. I think it's section 1202, but they're the range of E&M codes. See if I can pull it up really quick here. Let's see.
The 249.
Let's see, I've got it right here. They are 99201 to 99499. And so for that range of codes, the state Medicaid program will reimburse based on the Medicare physician fee schedule. And their state plan amendment went further. I think it also included a provision that raised the general physician fee schedule to 87% of the Medicare rate, with the addition of that specific enhancement for the E&M codes. And in looking at their fiscal note that was attached to it, it was around $63 million. You think about North Carolina, they're about more than double the size of our population. I think their Medicaid enrollment is almost exactly around double what our enrollment is probably hovering at now. And so it almost seems like it's a relatively low investment that could probably drive pretty valuable outcomes. So it just might be something worth taking a deeper look at.
What was the number, Cody, that you found it for that? What was the number that was their investment?
63 million was about the total cost of their that was attached to their state plan amendment.
Well, North Carolina's just really beginning this, and as I pointed out last time we met, Florida and several other states have done this for some time, paying Medicare rates for primary care physicians. Some of you might remember, but we had something called KenPAC. That was a per member per month that we paid if you would accept Medicaid patients. And we did that for about 10 or 12 years. And the problem with it, according to DMS, was that we didn't really increase access to care like we should have, because we didn't require those doctors who took the KenPAC payment to actually see those patients. So it didn't improve access to care like they wanted. However, North Carolina took that and ran with it, and it worked for several years in North Carolina. I have a lot of friends that are pediatricians there, and it kept their doors open with this per member per month, which I still maintain would do better than just going to Medicare rates. But anyway, they finally decided after several years that wasn't saving the money that seemed to be with them. With us, it was more access to care. And with North Carolina, it was more an idea of saving money. But they ran with that, and then several other states did it. And I'm not sure if that's lasted anywhere or not. But I can tell you that per member per month kept a lot of us that were in solo and small group practice, seeing high Medicaid numbers, kept our doors open. And that's where we get again into this rural versus urban, or rurban, if you would. I live in Owensboro, which was at that time the third largest city in the state. And I can tell you that, 60% of our children are on Medicaid, and my practice was 75% Medicaid. And that's pretty close to what's going on in a lot of the rural areas. So this was what I call a urban area, but yet we had a Medicaid desert here if we wouldn't see the patients. So I just want to make those points. The Academy of Pediatrics has just finally, to me, awakened to the fact that we have to look at reimbursement for pediatricians, or they just simply won't exist. And so they're calling for a transition of Medicaid from a state by state to a national program, so that all, at least they're talking about primary care as well as just pediatrics, would then get Medicare rates at least. So at least some of the national organizations are starting to awaken to the fact that they have to address reimbursement, or they won't exist because their members won't exist. So I'll stop there and let you take it, Chuck.
Thank you, Dr. Neal. Dr. Gupta, I see you, but I'm going to ask Dr. Patel to come in first, and then I'll come back to you if it's okay.
Thank you, esteemed speaker. So I agree on all points, right? I have seen that work report, and I did practice in North Carolina from 2001 to 2009. And to give you guys a little bit of history, it was called the Brody School of Medicine in Eastern North Carolina. So that would liken to your Eastern Kentucky, right? It's called Vidant now. And the genesis for that school to be created was to fulfill the clinician work shortage that was to come in Eastern Kentucky. I mean, it's very rural if you've been out there. And I went out there to do my residency, my chiefship and my fellowship, but my wife came on as a fourth-year resident and then as a fellow. And the day she got there, they asked her if she would stay on for 3 more years after her fellowship, which aligned with when I was going to finish my fellowship. 3 more years in rural Eastern Kentucky, Eastern North Carolina, Tarboro. If you guys are familiar with Tarboro, it's just up 54. And working at FQHC Monday through Friday for 3 years. And they give her an option after 3 years for her to have her loans paid back, or they would put her in an incubator plan where they would open shingle and shop, right? Free AHR, because ACA was just coming at the time, right? They were going to use federal funds. And so her fellowship partner is still out in that community, now has 3 docs, is running that FQHC. And so we could definitely, I think there's multiple levers you have to pull, right? You have to attract new docs, you have to attract international medical grads, but there is no replacement in keeping the people you train, right? They know the community, they've treated people for 3 or 4 years through residency. They know the community, there's no replacement for that. And you know, I agree with some of the previous speakers. You got to get a hold of those medical students, flourishing medical students early on and tie them to your community. Almost like how they do in the military, right? For your service, they keep you in the service. You're always in service. And so, you know, there are models like that. I think North Carolina is the gold standard. Georgia actually has a new medical school opening. I don't know if you guys have heard. It's in Marietta, Georgia. And they're using that same Vidant Brody School of Medicine model to put people in Northwest Georgia. And so I think there's a lot of models out there. And what is the saying? There is no better form of flattery than mimicry. I think I got it wrong, but you know, there's no shame in copy, right? And so I don't think you have to reinvent the wheel. I think there's a lot of things already out there. We just have to be less passionate and emotionally tied to the old way of thinking. I think rates are totally important. But let's just be honest, right? We throw a lot of money at physicians and clinicians to do quality work, and you still leave that money on the table. Because the answer is not just always about the money.
No, there wouldn't be any pediatricians if it was about the money. None of us got into it because of the money.
Absolutely. I totally agree.
And one of the things you mentioned there was the federally qualified health clinics. And Dr. Thornberry, I know you can speak to that too, because we've been trying to figure out what percentage of the rural patients are being seen by either rural health clinics, which are different from federally qualified health clinics, but all of them are reimbursed totally differently from the way.
That's what I mean. I mean that, you know, they make 3 or 4 times what I make. You know, they make $300 maybe for a 10 or 15-minute visit. I mean, you're talking about apples and elephants. These aren't even in the same category. No wonder they can afford to do that. I mean, if I had that.
we've asked the MCOs to try to develop the information for who is seeing the rural patients, because the codes are the same. I'm not gotten that information back. I don't know if there's anybody on our call today that can give us some of that information. That's what we've asked. Who's seeing the rural Medicaid patients? Can anybody?
We have Dr. I don't want, I'm afraid I've lost Dr. Gupta. Do we have Ashima?
I'm
Still see her?
here.
Yes, you went from the top of my screen to the bottom. I'm sorry, Ashima.
That's
I
okay.
apologize. Yes, ma'am.
No, that my hand was raised from earlier in the session. I
Oh,
forgot.
I'm
to
sorry.
turn it
I'm so
down. Yeah.
sorry.
No, you're fine. I already spoke about what I wanted to speak about. So
Yes, ma'am.
Okay.
Well, well, Cody, with regard to this model here, what was the number that you said that they were looking at? What's that number?
And for North Carolina to do this, according to the fiscal note that was attached to the state plan, that was, linked within the state plan amendment that we had looked at, it showed about 63 million for the biennium for them to carry this out, which, I mean, again, I don't know what percentage of that also is going to be federal dollars, but I would imagine that's not all state money. But that was where North Carolina landed on it.
Dr. Thornberry, if I may
Yes, sir.
add
Yes,
a
sir.
comment.
Yeah.
I'm sure what I'm about to comment on is known by everyone, but I think it merits mentioning, and that is for specialties like primary care, pediatrics, and I'm going to introduce addiction medicine. These are specialties that may not see return on investment today, but we all know that if our primary care colleagues did not exist, it's going to increase the disease burden downstream tremendously. And if we are very, very shrewd with our finances, we need to recognize that for tomorrow. For example, in the addiction space, 80% of our patients are on Medicaid. And I think that there are numerous studies already in the literature that have suggested for every dollar invested into a patient with addiction or in primary care or pediatrics, you're going to have tremendous return on investment. And so, I encourage our MCO colleagues to go back and look at that and reconsider what we are trying to ask today, and look at the benefits and value. For example, I was just recently reading about the Hep C treatment. Treating every Hep C patient today is going to save, I think, something like $300,000 or $400,000 per patient in the future, in regards to not having to deal with the morbidity and mortality associated with Hep C. And I can list many examples of primary care and pediatrics where proper management of some of these chronic illnesses are going to return tremendous dividends downstream. And so I know everyone knows this, but I think it merits mentioning, because that needs to always be a factor during our consideration. So thank you.
Thank you, Dr. Tran. Well, the last data that I saw on this was something that came out a week or two ago, and I'm trying to think, Cody, you may have to help me source this, where for every 100,000 population, if you increased it one physician, the life expectancy expanded somewhere between 55 and 119 days, depending upon the way you diced it. Do you know the source on that, Cody?
I haven't got the source directly in front of me, but you are correct. The study proved a direct correlation between number of primary care providers in an area relative to the number of years of life expectancy. And I think the number they included may have been 100. I think it was like 155.1 days.
Well, that's kind of just, I mean, that's the most recent data point of Starfield's global model, which was the better primary care that you have, I think the better the population The problem that we have is we have a very, very high prevalence in Kentucky of chronic disease. You know, it's just not Vermont, it's not Colorado, it's not Utah. And so because of that, what's happened is the onus of primary care is, you know, from the MCO's point of view, Dr. Patel made a fair point. You know, if you're looking at it through their lens, well, we want you guys to do better quality. Well, I'm not convinced that the quality is bad. It's just, I'm just not sure that they're able to report it. They just, people like myself just get overwhelmed. You know, when I had medical students here, they just, it kind of overwhelms them to see the burden of chronic disease care. And these people aren't going to cardiology. They're not going to nephrology. You know, we're handling the overwhelming majority of that. We're probably doing 90% of that work. And then it's on top of that we have these other things that we're having to address. Again, that's the fair-minded point of, well, are you taking care of the immunizations? Are you taking care of cancer screenings? You know, and then on top of all that, you're talking to say, well, you know, how are we going to enter the health system? Do I need to see neurology or neurosurgery? Do I see urology or nephrology? You know, I don't understand where I'm supposed to go as a patient. Then the government kind of says, by the way, we have this transitional care thing we want you guys to address coming out of hospitals, because we're seeing between these care transitions, we're seeing a lot of expense and a lot of mistakes. It just says you burden these people so much. I don't think the doctoring is bad at all. That's not been my take on it. Looking at this for 30 years of my career, my thinking is the doctoring is actually very good. It's just that they cannot do everything that you ask them to do. There's not enough time to fill out the extra piece of paper because everybody else has their own piece of paper that they want. And eventually that piece of paper ends up, you know, somewhere in a report that wasn't generated or something that wasn't dictated. And if you don't do that, then in their view, it hasn't happened. And I think that's the frustrating part. And that's where I think, circling back to what Dr. Neal says, when you think about per member per month to support those people, it's almost like you have to find a way to give them something, or what you're going to get is what you're getting now. I just can't figure the long game out. I'm speaking out loud now, and I just can't figure the long game of the MCOs. I'm just going to just be direct. I just can't figure it out. Well, how is this going to be sustainable so that you all can come in to promulgate some type of service or to make a profit if it just keeps getting worse and worse and worse, and the only people that can really bail you out is your primary care? I just don't see how it's going to work out. I'm kind of at a loss. I guess I'm at a loss intellectually. I'm just not smart enough to be able to figure it out. And I don't know where to go. The best model that I think that I've come up with through AAFP is the North Carolina model. Are there any other, I mean, does anybody else have anything that would be more appropriate for us to look at? I mean, we have a workforce. Today we have the workforce to look at. We have 54, Senate 54 that we're looking at. We're trying to find all these different models. Dr. Neal, I know you have something on your mind there.
Yeah, yes, I do.
I can see you want to talk.
Yeah, North Carolina had another program. I think it's NC 360 or something like that, where they're finally getting to understand that the social determinants of health are the thing that's going to make their state and our state better. Because we've got so many people what are we, 48th and almost everything. And the only way we're going to come around is to get whole communities. Young people right now, I don't know if they really want a medical home. They'd rather go for episodic care, which we all know is not good. So we've got to get other people involved. And I think most futurists are writing that the physician is going to lead the primary care team, which is obviously going to include a lot of mid-levels with the nurse practitioners. They don't maybe know what they don't know, and so we can help them. And I think that they would like that. But we've also got to draw in the other social work people in the community so we make the whole community healthier. We're trying to do that in Owensboro with a citywide, countywide committee that is made up of everybody, all the stakeholders, including, bankers, construction people, the hospital, because it's the largest employer, trying to make their own employees healthy, to look at smoking, to look at drugs and those things that we've got to work on. So I think we've got to think bigger about that, and that's going to be the answer, is that physicians are going to lead this health team, but we've got to make sure that physicians are there to lead it. And that's why most of the articles I'm reading are saying we've got to invest in primary care. So I'll stop.
I want to pitch this to Tim first. Tim, I appreciate you waiting on me. And then I have Sarah right behind you, Tim. Sarah, you have to be patient, okay?
Hey, thanks. Hey, everybody. Tim Houchin. I'm a lifelong Kentuckian for the most part, but I did practice and train in 2 other states over the years, Vermont and New York. And I'm an adult child and forensic psychiatrist, and I do work for a managed care organization, but I also do most of probably the murder cases in Kentucky. So I evaluate folks charged with doing terrible things, and I also take care of little kids that have mental health problems, and and my wife is a pediatrician. And one of the things that we talk a lot about at the dinner table is the extreme autonomy, because she also lived in New York and Vermont, the extreme autonomy given to APRNs in Kentucky, to the point where when I meet with a hospital administrator, I mean, they tell me, we just really love hiring APRNs because they cost a third of what a doc does to hire, and we can bill almost as much for them. And so I guess that would be a concern of my wife's and mine. How do we differentiate, ourselves as physicians and lead when perhaps organizations often prefer to hire our APRN counterparts?
That's a fair-minded question. I mean, I think that's more a question from the legislature. I always felt like that was more educational legislation. They came in and said, well, we feel like that we can do this. They did get that authority, and that's what the Commonwealth has promulgated. That's what I have to live with. But I think the most recent evidence from Hattiesburg and both the VA study that came out last year, I don't think that it's worked out very well. I think if it did work out, we wouldn't need medical schools. Why would you ever spend that long training if you didn't need to do that? That's beyond the discussion today. But then again, I think if the MCOs say, well, in our wisdom, we think that we can run a system based on the APRNs. I don't know. I'm married to one. I've trained several of them. I work with them. I feel like I have a pretty fair idea of what their capabilities are. I'm not sure it's going to work out for you. It might. I don't know. I mean, I feel better if I was spending billions of dollars, if I had another model that said, you know what, this looks like it's going to work out for us on paper. But that's not my call. That's the MCO's call. I'm just trying to say, I'm trying to go by the model that Starfield promulgated, because that looks like the most viable model that I've seen work. And again, my buddies, you have friends on the West Coast just like I do, but my friends at KP told me it didn't work at all for them. Now there's a place for them, but and it is a very valuable place in our team, but they saw it more as a teamwork. But I guess I don't know, they probably have their own TAC. I'll let them speak for themselves. Sarah, did you want to chat in here?
Yeah, I always love to contribute. So, I've been speaking with you guys with the KMA and other sources, and I think the points that Tim and Dr. Patel are really important. Like, I think we've found ways to change the system to help our hospital systems out. So the doctors employed by that, the hospital rate improvement. We've got ways with the FQHCs. And so for us, our members are covered. I don't have the data in front of me now, but happy to share that with you, how our patients are getting access to care across the entire state of Kentucky. I think maybe we could debate on quality and other metrics. But I do think the care that independent physicians provide is very vital. And I don't, as you guys are all speaking and talking about, I don't know if we have a solution for that yet. I know you've heard me talk about value-based care and how that can really change the model from that fee-for-service, which really is not working for our independent physicians, and trying to group some of that payments together. So we are paying for those preventative, we're getting higher payments, we're getting that shared savings. So if you're taking care of your patient. You don't need them to see specialists. You don't need them to have tests done. They don't get admitted to the hospital. Then you get some of that money that otherwise would have been spent had they been seeing someone else. But I'm not sure yet if that quite works for you guys, as you guys keep saying. I don't know if you've been able to use that model like we have intended. And so I don't know if there's a way to work with that, or as others have mentioned, copying other states and other things that have worked to try to get more independent physicians into rural communities and across our state.
Thank you. Yeah, I mean, I think, I don't know, my knee jerk on it is, well, again, the FQHCs, they don't make like 20 or 30% more than I do. They make 3 to 4 times what I do for a visit. The hospital doctors don't have to worry about it because they get paid the same as Medicare, and I don't. They have a lot of people. When you talk about value-based care, I guess the biggest model I have is the national ACO system. They all lost money except 4 or 5, and I don't think I'm as smart as they are, and I certainly don't have as many people. I'm sure you guys have a whole room full of people that are pretty darn smarter than I am on that kind of thing, and I just don't know how I'm not sure how you all see it as the primary care people have enough to do value-based care. I don't know how they would be sophisticated enough to do it.
No, yeah, I mean, I agree. Independently, I think it'd be tough. So that's why I think a lot of you are part of different organizations, whether it's APCP or I think Lexington has one now, but using that organization to help you achieve that and get some of that shared savings, and then have those extra resources as well to be able to support your practices. And I think I sent a PowerPoint over ahead of time with more information that you guys can look through and see if, and just making sure you're using our resources to kind of help you achieve that. I think the hardest thing for independent practices, like the model of care, is really switched to, it's not just the person who you see in your office. You're like, we're holding primary care offices now accountable for everyone who is attributed to them. And so it's, how do you use our resources or your organization's resources to bring them in? And so you're making sure that you're not just testing for colon cancer or someone who has lots of chronic diseases and is seeing you every month, but also those that maybe aren't accessing care.
Chuck, let me correct one thing you said earlier. Maybe I misunderstood you, but you said the doctors employed by the hospitals don't have to worry because they're getting Medicare rates already. The not-for-profit hospitals were granted Medicare rates for their outpatient services. However, I've talked to several hospital administrators and their financial people. That's not getting passed along to the primary care doctors. That's one thing that I want to make clear.
Yeah, and then that's I guess that's that would add a little bit more fuel to the fire there, which is, of course, when you work in a health system, those are much more sophisticated entities. So while they may have negotiated that as part of their overall sustainability, the thing is you're right, it's not getting down there to the primary care doctor, which is the great irony here you see is the fact that if you were an MCO that actually did pay it to the doctor, where it actually got down there, it would make a difference. Do you see what I'm saying? They're paying it over here, it's not getting to the doctor, and over here they're not paying it. You see what I'm saying? Maybe I'm not articulating it well.
Dr. Thornberry?
Yes, ma'am.
I'm sorry to interrupt. I do have to step off the call at 11 for like 15 minutes.
Yes, ma'am.
I didn't know if there was a recommendation that we were planning to vote on.
Well, we had talked about the possibility of asking the MAC to look at this or at least asking DMS, having the MAC request DMS look at a cost forecast for this North Carolina model. The back of the envelope math that we did looked to be sustainable, and it looked to be like something that you could do to try to support the communities that, again, I think that I don't see any other way to support primary care except to pay them better. And we're trying to find a sustainable way to do it. That's the most sustainable way that I have seen. Cody, do you have any thought on that before we bring this up?
You know, we've looked at a lot of models, talked about a lot of different things, and in terms of what I've saw, I mean, the North Carolina model seems to be the most direct, targeted model that I've looked at, and it seems to be fiscally sound. So I don't have anything further to add to that.
You know, Chuck, we've got to convince the legislature that there is a problem and to recognize that we're heading for a cliff pretty quickly. And there are more things involved than just the money, but they've got to understand that. And I think we've got to take that message to the legislature, and that it's not that we're demanding money, we're demanding a healthier state, which will save them money in the long run. Probably not in their lifetime or ours, but we've got to do it.
Well, I think, again, I think that the intent that we had is this is the best model that we've seen. It might be appropriate to consider moving this up to the MAC, moving up to their level and say, listen, you guys kind of look at it like we did. This is the best model we've seen. If they felt it was appropriate, maybe they could ask DMS to say, well, would you all take a look at this model and see how sustainable it is? And that might give the legislature a little room to consider a model like that, or some hybrid model. Perhaps an even better model could come out of it. That would be my suggestion. But that would be the topic on the agenda. If somebody wants to make the motion, we can consider it as a body to move that forward, or we could just leave it where it's at today.
Having served on the MAC, I can appreciate the situation Asham is in at this point, because for years because that's where you've got the dentists, you've got the home health people, you have all the people who feel that they're being underpaid for the services they're giving. So I think that it's got to come up there.
Well, do you think is that a motion, sir?
Yes.
Okay. Is there a second for that motion?
I second it.
Any discussion from the panel on that? Guess not. All in favor then?
Aye.
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 Any objection? Without objection, then we'll move that forward. Ashima, I know you have to get off here, okay?
Yes, I just want to say one thing. So Cody, because I'm going to be presenting that next week at the meeting, or in 2 weeks. So it would be nice to explain what that model is, right? Of course, because most of this is education to the MAC about what that model is. Would you be able to provide me a little write-up on that?
Yeah, I'll get you all the information that you need.
Okay, thank you.
When do they
I'll try to
meet?
be, sorry.
When do they meet?
The Thursday after Thanksgiving.
Okay, thank you.
I'll try to be back in about 20 minutes.
Thanks, Ashima. I hope we're gone
Okay,
by
thanks. Okay,
No, yes. If I'm good, we'll be gone.
that's what I was thinking.
Yeah, we are.
Okay,
Trust
if
me,
so, happy Thanksgiving.
I'm pretty good at this. Dr. Tran, let's move you forward. We have another issue you'd like to bring forward, sir?
Yeah, the one topic that I recently heard about is that Medicaid across the board has introduced a new platform for the purposes of initiating PAs. And I was hoping there was someone here who could comment a little bit about it, and also comment on whether or not the population has been properly trained or given adequate training before implementing the platform.
Hi, this is Justin Derringer again. Thank you for bringing that up. We have a new prior authorization provider. The prior authorization process should remain exactly the same as it has before. And as soon as the system's in place, we will start training providers, sending out information about any changes that they may see, about anything that's different that's out there. And in keeping with that, I wanted to let you all know that we are also reviewing all of the prior authorizations and looking at utilization and things like that to hopefully reduce some of that extra administrative burden that you all have, not just with prior authorizations, but with all areas. So if there's an area where you feel like there's just an administrative burden on our part, as far as when I say our part, I mean Medicaid, that you all are struggling with, and it doesn't have anything to really necessarily do with quality of care or something like that, feel free to reach out. I'm going to send that to my I'm gonna put that in the chat, my email or my division email address. Feel free to send us that. We are constantly looking at those from providers. I want to let you as a TAC be aware of that. We get probably 20 requests a day from providers and provider groups about different things that we can look at. A lot of it is rates. The majority of it is rates, but it's also code additions, code deletions, changes to limitations on codes, all those different things that we look at. But we also have a special group within our division that gets together once a week and looks at requests from providers for any administrative burden that they may have. And we've been able to eliminate within the last several months multiple administrative burdens that were kind of in the way for providers. So just kind of let you all know that's available too.
Thanks, Justin. Dr. Tran, did that answer your question?
Yes, I'm glad to hear that. And Justin, that was awesome. I'm glad only because my understanding of the platform is such you're trying to streamline, and I think there's going to be more accountability in regards to the process. All of these things sound great on paper. I'm a little nervous when a huge platform is introduced without proper training of the group and the population. But thank you for reassuring me that that training will come.
If that answers your question, I'll have to try to clean up our agenda here and move us back to one of the early items. We had initially invited one of our colleagues from the physical therapy TAC. Can I assume that person, Georgine, never made it?
Yeah, Dr. Thornberry, he had communicated.
Sorry, Cody.
Oh, it's okay.
Go
No,
ahead.
he had communicated back with us that he won't be on today.
Well, can we go ahead and address this? I think this is something that they wanted our input on, and I don't see this anything that's going to be controversial, and I do want to support them. Cody, would you just go ahead and set this up about the documentation issues?
Sure. So they had reached out and stated that therapy practices have expressed a difficulty in getting a physician's signature on their plan of care before submitting the PA request, and that this has grown to be an administrative burden both for them and for the physicians that they're working with. And they also shared that often it takes over a month to get a signed plan of care back from a physician. And so, which of course, on their end, they say causes a delay in providing treatment to the patient. And so they've shared with Kentucky Medicaid, or they shared with us that Kentucky Medicaid had shared with them that a nurse practitioner or an RN can also sign the plan of care as long as they're in the same office. And then what they're asking for is for Kentucky Medicaid to allow them to submit the plan of care for authorization as soon as it is written, and then just submit the physician's signature on the plan of care once they have it.
Well, the short of that is, I mean, that's not exactly our bone that I see. I understand their concerns, and I don't take any issue. I'm not sure what he's asking for or they are asking for, but I don't see any issue at all by, if they'd like our blessing to say, is that okay with us? It would be certainly fine by me. Does any of the TAC members take an issue with their stance? I mean, they're just delaying care because of a paperwork logistical issue on getting a signature on an order that's already been written. I would say we would support their effort, and if they put that in front of the MAC, I'm sure that we would be happy to support that if that's what they're asking. Am I reading that correctly, Cody?
Yeah, to me, it just seems like an administrative check that they need to get the signature. The way it is now, they need to get the signature prior to submitting the PA. They're just asking that they can submit the PA and then submit the signature once they have it post.
Well, again, I mean, the way I look at it is the care. I want the care to follow the patient in the most efficient way. this again is just the order's already been written. The plan of care would be defined by the therapist, and to get that oversight, I mean, that signature, I don't see that, I don't see how that's helping the patient. I don't see that's helping us, but you know, if they wanted our support on it, does anybody take exception to that? Okay. Well, I would just tell them that, Dr. Tran, do you have a thought?
Yeah, I wanted to express that I concur with the comments made. The intent has been delivered, and these administrative things should not interfere with or delay patients' care. So I concur.
Well, I would say that therapeutic, I think that's right. The therapeutic intent is there. I think you can communicate to them. I mean, there's really not a vote to take. I mean, it's their issue, but we would support that. And I don't know why we wouldn't, or anybody wouldn't do that, but we tell them we've discussed it. As far as the TAC is concerned, we would support their position on it. And we appreciate them at least, you know, letting us have a thought on the matter. Okay. We do have one other item. I understand that we've been debating a few years about trying to get our meetings more to a quarterly basis. When the PTAC was first initiated under Title 19, there was probably a lot more. I think things were a little different at that time, if I understand that. Dr. Neal can probably chime in a little bit about that. But I think that the question was, can we move to a quarterly schedule, which is kind of functionally what we do, at least under my chair. I've tried to have the committee here. It's a lot of people, it's a lot of expense, and it's a lot of time. And that doesn't go unnoticed. I mean, on all parts, on our MCO colleagues, on the Commonwealth's DMS division, and for the physicians and the administrative staff behind us. So I try to only bring us together when I think there are at least meaningful updates to have. I feel very comfortable going to 4 meetings a year, which pretty much is about what I try to drive anyway. We can make it more formal. Are there any community members that would like to talk about that?
I think quarterly meetings will be fine. I can tell you that all the years that I've served on the TAC, when we met together, it was so helpful to look across the table at the insurance companies then. They weren't MCOs, they were insurance companies. And we dealt with them directly, and we tried to solve problems directly and have them take it to the Medicaid department. And that's what I like about in-person meetings, and I wish we could have some of there. Of course, we have 5 MCOs now. And I know one of the head legislative people would like to cut that to 3. So we'll see how that pans out.
Well, I would say yes. And I think that's sometimes the thing that doesn't come across, which is in our position in the health system, what we're trying to do is to find sustainability. What I want is I want an MCO partner that is profitable because they can promulgate their care, and that they're an important piece here. I'm just trying to find a way for us to do it in a sustainable way so that the whole system is sustainable. That I think is sometimes we end up to do some dialogue that's a little assertive because of our passion on that. But again, I think that the goal is still the same for everyone. The goal is we want to have a sustainable system so that everybody can succeed. Because when everybody's succeeding, well, those are places that businesses want to come. The physicians want to come, that the communities want to leave other states and say, we'll vote with our feet and our money. We'd like to come here because this is the place that we would like to have a family and a life. And so one of the important infrastructures in any place that a business or a community come is, well, what's the healthcare system look like? What's the population look like? And that, again, maybe thinking of my primary care hat on, that's part of what I'm about. Every primary care physician in the community drives about $2 million in that community. And so the more that I have of that, the better our care, I think, and the better our Commonwealth's going to be. But that being said, I would say, is there a motion for us to encourage a 4 times a year meeting? We've tried to pull that up with DMS before, I think a few years ago, and they kind of pushed back on that a little bit for some reason. I'm not sure why, but
Dr. Thornberry, this is
Yes.
Erin with the Department of Medicaid.
Yes, ma'am.
Since I've come along and been the TAC coordinators for all the meetings, I've always
ma'am.
been told that the meetings are up to the TAC. So if you prefer quarterly, I know we had a few people, and again, I've only been doing this, I've been with you guys, 2 years? So I'm not sure prior to that, but I had a few other TACs asked, so I did want to offer that to some of the other TACs. As far as meeting in person, of course, that is also up to the TACs. I'm happy to coordinate. I just need notice. It is public, and also hopefully our public health suites are fixed. They had some pipe busting last year in the winter, so they should be ready because the CHS building is now currently under construction. So I'm happy to host in person. If you could give me a few weeks, because I do have to let the public know, our MCO partners, and of course I need to notify the court reporter as well. And we can always do a hybrid if I know some people may travel. So I'm happy to put together a quarterly schedule on the email that I had sent out, and we can kick emails back and forth and figure out what days work best for you guys as a whole.
Well, that would be wonderful. You would actually earn the TAC Member of the Month award for that.
Woohoo! I win.
Hearty congratulations. I think we'd like to. I think the sentiment would be to go to 4 meetings a year. I want to respect all the members and how their schedules are. I know how mine is sometimes. I really would like to at least get together once a year. I would love to get together if it's possible twice a year in person, but I always would like to try to do that. I just think people are social beings. I think you can accomplish more in person, and I think that there's a lot to be said for that. I think asking to get people to get together 4 times a year in person in today's society, I think that's a lot to ask. And so if maybe Cody, could we maybe work with you and try to work with some of the members, and then kind of move out from there? From there, can we get to the NCOs, and then from their leadership, can we move to DMS and see if we can find a way to, would that be agreeable to everybody? Maybe 4 meetings a year and try to do at least 1 or 2 in person.
Yeah, I like to summarize that in a motion, if I may.
Please, would you?
I would like to motion that the TAC meet quarterly, and I would like to emphasize the desire to have in person, but we should accommodate the virtual option as needed, and that allows people the freedom to jump in, participate via virtually. But if they can, it is desirable to have them in person, and that way we don't have to throw around exceptions, and it's quite a bit of time to email people back and forth before the meetings, and that just allows everyone the opportunity to attend in person.
Is there a second for Dr. Tran's motion?
I'll second.
Okay, any discussion on that? Any further discussion on that? Nothing. Dr. Linden, nothing, sir?
Cody, this is Erin. I can send you those dates after the meeting and maybe look at, maybe not, I'm assuming the January date, you might not want to meet in person, but we can look at some of those next dates. And just for the record, I do communicate all changes to all DMS and MCOs. I have a big distribution list, so they all get something from us very often. So I can work on that, Cody, to take that off your plate and get it over to you. And then you guys just let me know if you don't like those dates. We can work with them and wiggle around and see what's most accommodating.
Yeah, that sounds great.
Very good. The last thing I really have here is I want to be apologizing to Dr. Jones. He had his hand up and I didn't see the chat. I have like 4 screens open here, and I didn't catch that one. Tom, are you still here with us?
Yes.
Would you take just a minute, or not a minute? Would you take a little time to? I really value what you have to say, and I'd like you to. There were some very good points here. Could you just, for those that didn't see this, could you just take a few minutes to kind of help us understand your view, please?
Sure. And because this is a tough area. I'm med peds and I see patients on weekends, so I understand where we are. And I was in an inner city practice before and in a suburban practice, so I've seen all kinds. When I was with one other organization, I got to know Dr. Frank Opelka, who is the American College of Surgeons lead for quality efforts in Washington. He also ultimately became the assistant chancellor at LSU. Frank said he really thought that the way for physicians in primary care to be functioning at the top of their license is for them to have a series of nurse practitioners and or PAs under them who would do a lot of that administrative task in terms of making sure that all the preventive services were being taken care of, making sure that all the notations needed were there, because it is tough. If you're scheduled on a 15-minute basis right now, at least for me, I spend 8 minutes with the patient and 7 minutes with the chart. So it cuts that down significantly. If you've got other people who can do that. Now, there obviously has to be a system in place to be able to cover those costs. And that is one that where I was part of a Dartmouth Brookings ACO, one of the ones that did make money. And we were able to fund a nurse practitioner in each of the sites within that ACO to do just that kind of thing. So I think it's going to take a lot of people working together to look at the finances, looking at getting physicians to work at the top of their license. And that's why the last thing I put in there was I was on the AMA webcast. I'm Kentucky's representative in the senior physician section because I'm the oldest guy who's still willing to do it.
Well, don't forget community health workers too. That can really help.
Oh yeah, and that's a great point there, Dr. Terrio. But anyway, they listed the specialties with the highest burnout. Number one being ER doctors. Number two being hospitalists. 3 are internists and family physicians. They lump them together. 4 are pediatricians. I did not see the surgical specialties on that list.
Well, I have a couple of thoughts. The first thought is I can tell you how we do it in our practice for sustainability. I'm going to talk about Medicare since that would make more sense to us. We have our physician assistants do the work of the Medicare annual screening, which is the well care portion. If we had more physicians, we would leave it that way, but we don't. So we also shift much of the stable chronic disease care that's non-problematic to them. And what that kind of does is, at least in my practice, the weight of that unfortunately falls to where I end up with the really problem cases. So I'm sure I'm some red line and some code where I bill so many 4s and 5s. It's just ridiculous. But the patients that I get are always the complicated. In my practice of probably 5,000 or 6,000 people, the people that have the trouble end up in front of me. Mm-hmm. And we just feel like it's more sustainable. I can't see as many patients a day by any means. I have to take, usually my patients are 20 to 45 minutes, maybe sometimes an hour, but they're very complex patients. We're just trying to keep them out of the hospital or trying to keep them sustainable. And we try to work backwards. So we believe in that model that Dartmouth Brookings used. And I would say congratulations that you're one of the few. And there are many lessons that I would love to learn from you. The second, to your second point, I would say that yes, the burnout, of course, emergency medicine, hospitalists, IMPs, family medicine. You know, the thing that happened this week, I don't know if you saw this, and I want to be a little sensitive about this, but, you know, we had one of our nursing colleagues here in our country, you know, have a self-inflicted death because she said of her oppressor, and the oppressor was the health system. And I thought that was just a really terrible thing to say. Unfortunately, that is I think a lot of us see that is what's happened. It's become the truth of it. You know, I mean, I just laughed about, you know, how I see it sometimes on TV, these old movies where the doctors would just take Wednesday off and play golf. And, you know, I mean, we have date night now with Epic on Friday, Saturday, and Sunday nights instead of spending time with their families. Instead of getting relief time to recharge, it's like they're going all the time. And I think that this is one of the considerations that, I mean, I'm having people younger than I did, people that I train now are retiring from, basically they're quitting. That's a euphemism. They're quitting medicine for other things because they just don't enjoy it anymore. And that's part of it. It's just not that you just retire out. It's just that we're seeing more people leaving medicine. And I don't know. I think a lot of us that still care about it are trying to make it better. I really appreciate, Tom, you taking time to kind of let us know. Judy, did I hear you chime in? Do you want to say something before we get off here? I always love to hear from you.
Sure.
Sure.
I was just gonna point out that you can have, I don't know why my camera's not turning on there. Have community health workers in your offices now, and Medicaid will reimburse for their visits. And so if you're seeing the patient, you know, with high blood pressure and diabetes and everything's out of control and sleep apnea and, you know, they're depressed and all this stuff, after you leave them, after you do your, you know, the doctoring stuff, you know, the community health worker can sit down and say, okay, you know, why can't you get your medicine? You know, and work through, you know, maybe they want to get their medicine. Maybe there's reasons they can't, you know, go to the pharmacy and get it. But, you know, work through all of those social determinants of health things with the patient, and follow up later to make sure it happened, and really work with them to help you know, get things done. And then you're not doing it, and so when they come back to see you in a month or 2 months, they've actually, you know, made a little bit of progress there. And I think of community health workers more like a mid-level for a social worker, and so they know how to get people in touch with resources. They know how to, you know, to get things done. And so if you don't have community health workers in your office, we have one at CNY. I mean, they're invaluable to, you know, you feel good about handing the patient off to them. They see them in the office, and they actually help get some things done. So something to look into.
Judy, I'm going to embarrass myself a little bit. We in our office, we use kind of our medical assistants in that role.
Mm-hmm.
Can you tell? Can you educate me a little bit about the credentialing? What's necessary for a community health worker?
It is the Department for Public Health runs a little course and certifies the community health workers. And I think you can find that on the Department of Public Health's website. And then once they're certified, you can, you know, with Medicaid, you can bill for them. And Justin knows the amounts. I forget what the amounts, the reimbursement is, but they can meet one-on-one, or they can meet as a group with patients.
Yes, ma'am. Thank you very much. Well, it's a full day. We're a little early to leave, and I want to be sure that I cover everything that we need to. When's our next meeting, Cody?
Yes, that'll
Do you
be
know about
pending. That'll be pending the meeting dates for the quarterly schedule.
Okay.
Either
So
way, it should be January 19th. I think
yeah,
that's
it's usually
the
in
same.
January. Yes, ma'am. Thank you. Is there anything else that we need to bring up or chat about today, since we have some extra time? Anything that our MCO colleagues or the department would like to pitch out here? I don't know if we can solve it, but we can try. Probably not. If I'm between you all and lunch and going home, probably not. So with that, I'll call this meeting adjourned, and we'll get together here in January. I want to be sure to thank again the senior leadership, and Justin in particular, you from the department. I want to thank all of our MCO colleagues, particularly all the medical executives that took their valuable time to be here and to chime in. I know it is contentious sometimes, but I want you to know that we are actually on your side, trying to save money, trying to make the system work. But thank you for putting up with us, and particularly all my colleagues. I know Dr. Goodwin was here, but Dr. Linden, Dr. Crane, and Dr. Neal, our chair emeritus. Thank you all very much. This meeting's adjourned.
See ya. Have a happy holiday.
Happy holiday. All. Thank you all.